Hello everyone, I'm Dr. Neeraj Kalra, an orthopedic surgeon. Welcome to my channel OrthoZone with Dr. Nee. So as promised, I am ready with a video on CAM-type of FAI. In a few seconds, you will be seeing a PowerPoint presentation on your screens, which will guide us through the basics of CAM-type of FAI. And I will be in the cameo video in the corner on all of these slides to give you insights and explanations. So let's dive in and understand the basics of FAI, and I'm sure you all will find this video super easy to understand. Thank you. Okay, so let's get started. So FAI is Femoroacetabular impingement. It was previously known by the name cervicoacetabular syndrome or acetabular rim syndrome. So what happens in FAI is principally a motion-induced hip pain. So when hip goes into flexion, there occurs an abnormal contact between the femur and the acetabulum, which leads to labral damage and various degrees of chondral injury. Now, it can occur in hips with abnormal hip morphology, or it can also occur in hips with normal morphology but with excessive range of motion, like belly dancers, athletes, etc. Now, pathoanatomically, FAI is divided into three types by Gans et al., which is CAM, second is pincer, and third is mixed. Mixed being the most common variety, which is followed by CAM and pincer. Now, with this slide, I would try to make the understanding of CAM super easy. Let me just use a pointer here. Yeah. So on your left hand side, you see this blue sphere, and also you see this brown cup, which is matching the sphericity of this blue sphere. So if this blue sphere were to rotate within this cup, quite obviously it would do it very smoothly. Now imagine this sphere is converted into something aspherical like this with a bump like this. Now if this has to rotate, this bump will hit against the stick, making the stick move or translate, right? So this concept is used in machineries. Now imagine this as your femoral head and this stick as your acetabulum. When this femoral head rotates in the acetabulum and when this bump will strike against the acetabulum, it would force the acetabulum to move. But acetabulum being a static structure, it won't move. So what happens instead is this rotating aspherical head would impart a shearing force over the articular cartilage of the acetabulum, leading to cartilage delamination and labral separation. I'll just show a video of how this works. Yeah, see. So this bump, when it reaches this stick, it is imparting a motion to the stick. The same way when the aspherical femoral head rotates in the acetabulum, it imparts a shearing force over the acetabulum, leading to cartilage delamination and labral separation. So CAM impingement, as I just discussed, is because of a non-spherical bony bump. Here you can see near the head-neck junction. It is found anterolaterally over the head-neck junction and usually found in young athletic males. Why? I'll discuss in a while. Let me just keep a pointer here. Yeah. So this sphericity mismatch in CAM type of FAI, what does this do? As I discussed in that video which I have shown to you a few slides before, the sphericity mismatch would cause shearing at the chondrolabral junction. I want to highlight this point here that it causes shearing at the chondrolabral junction first, not at the labrum. Labral involvement in CAM type of FAI occurs later in the stages. So after the shearing at the chondrolabral junction occurs, what happens is cartilage delaminates and labral separation occurs from the cartilage. This is something called as outside in trauma or inclusion type injury. Now, as per a systematic review by Marcin et al., the natural history of FAI is believed to lead to early onset hip dysfunction and arthritis, especially in CAM type of FAI and eventually THR. So the idea is to pick patients, at an early stage and preventing them from going into debilitating consequences, which we would be able to do if we know who is at risk, if we know the symptoms, and if we know how to examine patients with FAI and how FAI looks on X-rays, CT, and MRI. Which brings me to my next slide. So who is at risk? So congenitally, people who have increased acetabular or femoral neck retroversion, or people who have elliptical or aspherical head are at risk. Athletes who are into high impact sports, they tend to have excessive ROM, or gymnast, they can have CAM type of FAI. And FAI, CAM type of FAI specifically can occur as a sequelae of childhood diseases like DDH, SCFE, and Perthes. It can also occur following malunited fractures around the hip. Now, one point which I want to make here before moving forward is that as per a prospective study, skeletally immature individuals who are into high impact sports like football, basketball, they tend to have CAM type of FAI. Because see, in these people, what happens is repetitive and vigorous loading of the hip occurs at extreme ranges of motion, because of which there occurs an adaptive response at the proximal femoral physis, stressing the physis, which leads to the formation of a bony bump. But following the physeal closure, there is a limited progression of the CAM morphologies. So patients can come to us at any age, but the idiopathic variety generally comes to us between the age of 20 to 40. Also, one thing to remember is CAM type is more common in males as compared to females with a ratio of 14:1 because males are into high impact sports more. So so these patients would come to us with insidious onset activity related groin or hip pain, which is aggravated by the hip flexion. They also would be having difficulty sitting and rising to a standing position. Clicking, catching, popping might be there, and they can also present with gluteal or trochanteric pain due to aberrant gait mechanics. So now when the patient comes to us, he will indicate his pain holding his hip like this. This is called as a C sign by Baird. This means that the pain mostly is originating from the hip and mostly lies in the anterior and lateral aspect of the hip. We also have some impingement test for FAI. In the anterior impingement test, the patient will have pain in flexion, adduction, and internal rotation. Now, this is not a very specific test, but combined with other modalities for diagnosis, we can come to a conclusion that the patient has FAI. Now, these patients sometimes have unavoidable passive external rotation while performing hip flexion, and that's something called as a Drehmen sign. And I'm sure you all must be knowing about this sign in conditions like AVN and SCFE as well. Now, CAM, although mostly it occurs in the anterolateral part of the head-neck junction, there has been some evidence where it was proven that CAM has been shown to extend into the anteromedial and the posterior parts of the head-neck junction as well, in which posterior impingement test comes into play, where flexion, abduction, and external rotation would be painful. In this, we can also do one more test, which is called as Heber test, Heaber. HE stands for hyperextension at the hip, AB stands for abduction at the hip, and ER stands for external rotation at the hip. So this movement would be painful. Now, as important is the knowledge of examination and symptoms, equally important is to know how imaging should be done. For FAI, we need to have a well-taken AP view of pelvis with both the hips and an axial cross-table view of the proximal femur. Alternate to this is a Dunn or Ripstein view in 45 degrees of hip flexion, which I'll be showing in a while. So for a good AP view, patient needs to be supine with the legs in 15 degrees of internal rotation. The film focus distance should be 1.2 meters. Film focus distance is basically the distance between the film and the X-ray anode tube. So it should be 1.2 meters, and the central beam is directed towards a midpoint between a line connecting the ASIS and the superior border of the symphysis pubis. The cross table view, everything is the same except that the other leg is shifted like this in hip 90 degrees flexion and with the knee in also 90 degrees of flexion. And here the central beam is directed towards the inguinal fold of the hip being examined. This image again shows the cross table view. Here we can appreciate that the film is directed 45 degrees to the hip, and the central beam is directed towards the inguinal fold. So this slide shows how a Dunn view is taken in 45 degrees and 90 degrees of hip flexion. So for a 45-degree Dunn view, we keep the hip in 45 degrees of hip flexion and also 20 degrees of abduction. The central beam is then directed towards the midpoint of a line which is connecting the ASIS and the superior border of the symphysis pubis. 90-degree Dunn view is exactly the same, just that the hip is kept in 90 degrees of hip flexion with again 20 degrees of hip abduction. Summarize these views. Dunn view would give you an idea about the anterolateral femoral head and neck offset. The froglateral view would roughly give you an idea about the anterior femoral head and neck offset, and the cross table lateral view would give you an idea about the anterior femoral head and neck offset. Now let's come on to the interesting part, the specifics of CAM-type FAI X-rays. So you have obtained a view. You have obtained either a frog lateral view or a Dunn view or a cross table axial view. Now the things which you have to look at, which you have to measure actually in CAM type of FAI are alpha angle, head neck offset and head neck offset ratio. So now this is a cross table axial view of the hip being examined. So now I'll first draw a line in the center of the femoral head and neck. I'll then draw a circle around the center of the head. I'll now draw a line joining the center of the head to a point where the head exits the circle. So this line is joining the center of the head to a point where the head is just exiting the circle. So this angle formed is called as the alpha angle. Normally it is less than 42 degrees. If it is more than 42 degrees, it indicates some head neck offset abnormalities. But if it is more than 50 to 55 degrees, it definitely means that the patient has CAM type of FAI. Now for the head neck offset and the head neck offset ratio, I'll draw a line number 1, which is again bisecting the neck and the center of the femoral head. Line number 2 is drawn tangentially to the anterior most part of the neck. And line number 3 is drawn tangentially to the anterior most part of the head. Now the distance between this line number 2 and line number 3 would give us something called as head neck offset, which normally is equal to or more than 10 mm. If it is less than 10 mm, it indicates the possibility of CAM type of FAI. Now for the head neck offset ratio, I'll draw a line number 4, which is basically the widest diameter of the femoral head. Now head neck offset, which we have just calculated, if it is divided by this distance, so that would give us something called, so that would give us the head neck offset ratio, which normally is more than 0.17, and if it is less than 0.17, it shows the possibility of a CAM type of FAI. So on the anterior-posterior view, we see this classical pistol grip deformity in CAM type of FAI. You see this bump here? This bump is giving this pistol grip deformity appearance. Now, one thing which we need to keep in mind is that recent studies have shown that many asymptomatic individuals, people without the symptoms, can have FAI findings on CT scans. So this highlights the importance of clinical correlation and symptom-based diagnosis, and it also highlights the importance of avoiding the overdiagnosis of FAI. The link of that study I'll put in the description box below. So this was all about CAM type of FAI. My next video would be on pincer type of FAI, and I will be uploading that on Tuesday. Thank you so much.
So this was it. Thank you for watching. I hope this video helped you grasp the concept of CAM type of FAI and its implications. The key takeaway is to maintain a high index of suspicion for FAI in young patients coming to us in OPD with hip pain, because early detection and treatment can significantly improve the outcomes. Stay tuned for our next video on Tuesday, where we will dive into pincer type of FAI. Subscribe to OrthoZone with Dr. Nee for more informative content. Like and share with your colleagues, and comment below with the questions or topics you would like to explore. Until then, stay informed, stay updated. Thank you so much.